what my talk today is going to involve is what you guys should be doing before and after you do an intervention on many of these patients. There have been a lot of good trials now that have been published in the last 3 years that will help us not only decrease cardiovascular event rates, but also decrease limb problems. So there never before has been a problem related to that. These are my 2 disclosures. And basically what we're talking about today, or what I'm talking about, is peripheral artery disease, usually caused by atherosclerosis. And it not only increases, if you have it, it not only increases your risk of MI, stroke, and cardiovascular death, but it also increases your risk of limb events such as acute limb ischemia and amputation. Now, I'm not going to insult you by telling you what the ankle brachial index is, but what I am going to do is tell you how important it is in determining the overall prognosis of the patient. If you look here, the circled area is basically a normal ankle brachial index. If you're greater than 1.4, then you have calcified arteries, and your cardiovascular risk is increased with that. But as your ankle brachial index goes down, your cardiovascular event rate goes up. So these patients have a higher cardiovascular event rate than patients who have already had a myocardial infarction. Yet they are so undertreated. People do not equate the cardiovascular event rate with peripheral artery disease the way they do with coronary artery disease. Take a look at this. If you have, why is this outlining this? Well, anyway, there we go. So if your ABI is 0.9 or less, you have peripheral artery disease. And the yearly event rate is 2%. The 5-year event rate is 10%. If your ankle brachial index is less than 0.7, your yearly event rate is 3.8%, but your 5-year event rate is 19%. So I know you all talk about Framingham risk scores. A Framingham high risk score is 20% at 10 years. These patients have a 20% risk at 5 years. So they're a super high Framingham risk score. So this is really all you need to know. This is the PAD prescription. On the left in blue are ways to decrease the risk of MI, stroke, and cardiovascular death. On the right in orange are ways to improve symptoms, quality of life, and prevent amputation. And many of these overlap. For example, smoking, exercise of some type, statin use, as I'll show you shortly, and antithrombotic therapy. It's not just antiplatelet therapy anymore. For example, it's now been shown, and I'll show you a study or two, that high-dose statins not only decrease the risk of MI, stroke, and death, but they also improve symptoms, improve quality of life, and decrease the risk of amputation. Antiplatelet therapy is no longer just antiplatelet therapy. It should also be anticoagulant therapy. And this decreases MI, stroke, and death, but it also improves symptoms, prevents amputation, and is especially useful, as I'll show you data from the Voyager trial, in preventing readmissions for revascularization and amputation. So this is what we're going to talk about for the remainder of the time, the ways that you can make sure your patients have the lowest chance of suffering MACE, and now what's called MALE, M-A-L-E, major adverse limb events. This is one of the few 1A recommendations in the PAD guidelines. I think we all know this. I don't need to belabor the point. Smoking cessation is not only associated with decreased mortality, but improved amputation-free survival. It's really the single most important thing we can do for these patients, whether they undergo an intervention or they don't. Now, what about statins? Only recently has there been data on statins in PAD. This is from the National VA Administrative Database. It had a total of 150-some thousand patients. And they're looking at the intensity of statins on mortality and amputations. And the unadjusted model is shown here. I'm not going to talk about that, but Model 1 is adjusted for PAD diagnosis year, age, and the presence of coronary disease. Adjusted Model 2 is a fully adjusted model for all of the comorbidities that are associated with this. You can read this yourself. But what you can see here is that while low to moderate intensity statin is beneficial in both models in decreasing mortality and decreasing amputation, it's really high intensity statin that you get the most bang for your buck. So, I mean, now I think the guidelines are going to be recommending LDLs of around 50, that all of these patients should be on high intensity statins if they can tolerate it, because it clearly decreases mortality, and what was not known before, it decreases the risk of amputation. So statins, especially high-intensity formulas, are seriously underused. In this past study that I just showed you, only 6.4% of patients were on high-intensity statins. And this has been going on for years and years. This is the first population-based study to show that high-intensity statins in PAD patients has an effect on mortality and has an effect on amputation rate. Now, this is an old study. I'm going to show you two studies here. This is the NHANE study from Rena Pandey. And there were about 7,000 participants who had peripheral artery disease. About 6% of the 7.1 million individuals had PAD. It's a prevalence of 5.9%. Of these, statin use was only given to 30%. Any statin use, ACE and ARB, 24%, and aspirin use, 35%. In those patients who received these three drugs, their relative risk reduction was 65% lower than patients who did not receive guideline-directed medical therapy. Now, this is a study from Aaron Armstrong, who I think is on the agenda for later today. He looked at, when he was at University of Colorado, looked at over 700 consecutive patients with either claudication and critical limb ischemia who underwent peripheral angiography. And there's two things he looked at. The first study looked at smoking. And this is mortality. You can see it's twice as great. And amputation-free survival is much less in those who successfully quit smoking. But in this study, now this is a VA population, only 30% successfully quit smoking and maintained abstinence. But this was published the same year in a different journal. It's the same cohort of patients. And you're looking at major adverse cardiovascular events, MI, stroke, cardiovascular death, and major adverse limb events, acute limb ischemia, amputation, et cetera. And if you were on less than 4 guideline-directed therapies, smoking, statin, antiplatelet agents, ACE inhibitors, if you're on less than 4, your risk of major adverse cardiovascular events is quite high, whereas if you're on greater than 4, your risk is reduced by about 35%. Same thing for major adverse limb events. If you are on greater than 4 guideline-directed therapies, your relative risk reduction is 45% in major adverse limb events. So I can't emphasize enough how important medical therapy is in these patients. No, medical therapy is not going to get a patient to get up and walk 10 blocks in New York City, but it is going to help prevent them developing acute limb ischemia and major adverse cardiovascular events. You've all seen this. I'm not going to belabor it. I just want to give you a little historical background. So the thionopyridines are shown up here. Aspirin you're all familiar with. Now, I was on the steering committee of the thrombin receptor antagonist, Vorapaxar. We really thought this was going to be a home run drug. It interferes with thrombin generation. And the problem with it is it caused a lot of bleeding because it was used along with clopidogrel and aspirin, and that was a major flaw in the design of that study. So just quickly, historical background on 3 drugs. Capri trial compared patients with PAD to clopidogrel versus aspirin. And to get into the study, a third of them got in with a pre-existing stroke, a third got in with an MI, and a third got in with PAD. And overall, the study reduced major adverse cardiovascular events with clopidogrel by 8.4%. But in those patients who entered the study with PAD, this was a pre-specified endpoint in this study. In those patients, there was a 24% relative risk reduction in MACE, and that led to the recommendation that clopidogrel maybe is a better first-line drug in patients with PAD compared to aspirin. We really were excited about this trial. This is the ticagrelor versus clopidogrel. We were excited because of its effects in the coronary circulation. Unfortunately, we randomized 13,000 patients to this trial, and there was absolutely no difference between ticagrelor and clopidogrel. So this was a negative study, and we don't recommend its use in any of these patients. And then Vorapaxar. I'm not going to show you the main study results, but I am going to show you, we have published a few papers on the effects on the limb, and this was the first of about 5 papers. And essentially, Vorapaxar did not reduce the risk of cardiovascular death, MI, or stroke. However, it reduced acute limb ischemia and the need for urgent peripheral revascularization. And here's just an example. These were all pre-specified endpoints. They weren't the primary endpoint. But this is hospitalization for acute limb ischemia. And you can see in Vorapaxar, there's much fewer hospitalizations, about a 40% reduction. And there's about a 30% reduction in urgent vascular hospitalizations. With that said, this drug is never going to be used in any kind of meaningful way. The side effect profile is too high, and there's very limited indications for its use, although its mechanism of action is quite interesting. What about rivaroxaban? Rivaroxaban is a 10A inhibitor, and this is called dual pathway inhibition. So aspirin is a platelet inhibitor, and rivaroxaban prevents thrombin generation. So the first study that came out was the COMPASS trial, and in this study, patients were assigned to 2.5 milligrams of rivaroxaban, not Eliquis. People often mistake Eliquis because it's 2.5 milligrams, but 2.5 of rivaroxaban plus aspirin. They had a better cardiovascular outcome, slightly more bleeding than those assigned to aspirin alone. Rivaroxaban alone and aspirin alone did not have the same effect. So this is the primary efficacy endpoint: CV death, stroke, or myocardial infarction. And you can see here there's a reduction of about 24% in that primary endpoint in the combination, and it was statistically very significant, whereas rivaroxaban alone or aspirin alone had no effect. And death from any cause was also reduced by about 18%, and this also was highly statistically significant. So if you look at the Kaplan-Meier survival curves, you see aspirin alone, rivaroxaban alone, and rivaroxaban and aspirin, and you can see that this group did better than the other 2 groups, and it decreased major cardiovascular event rates or death, stroke, or MI by 24%. It did come at the risk of increased bleeding. So you see here that the bleeding rate is increased with a hazard ratio of 1.7, but fatal bleeding, non-fatal symptomatic intracranial bleeding, and bleeding into a critical organ was no higher. It was other major bleeding that occurred. And if you look at the subgroup analysis, every single subgroup lines up on the side of aspirin and rivaroxaban. Age, diabetes, geographic region, race, weight, etc., GFR. So a second and a third paper were then published in The Lancet, and I'm just going to show you one of those. This is the PAD subgroup. So about a third of the patients had PAD in this study, and those patients also derived a major benefit from aspirin and rivaroxaban. And if you look again, the reduction in the composite primary endpoint was 28%, highly statistically significant. The reduction in a secondary endpoint of cardiovascular death, MI, ischemic stroke, and acute limb ischemia was reduced 29%, again, highly statistically significant. So these are stable patients with PAD, symptomatic PAD, who were randomized to aspirin and rivaroxaban 2.5 twice a day. And if you look at MACE, every single subpopulation benefited. There were a small number of people in the study with carotid disease. I'm not going to talk about that. MACE or major adverse limb events, MACE and major adverse limb events, MACE or major adverse limb events, and then major bleeding. Everything is on the right of the line, and we know that it comes with an increased risk of bleeding. Now, why would this happen? Why would a low dose of rivaroxaban help somebody who has peripheral artery disease? Well, this paper that was led by Jagat Narula and his wife, Navit, she's a pathologist, and she took 95 patients, looked at a bunch of amputated limb specimens, and came to the conclusion that if you have femoral popliteal disease, predominantly it's atherosclerosis. But if you have infrapopliteal disease, there's a high rate of thrombus, chronic old thrombus, and very little atherosclerosis. So this may be one of the reasons why a drug like rivaroxaban helps atheromatous or thromboembolic events go down into the lower extremity. And here, this just depicts this. You see atherosclerotic plaque in the fem-pop region. In the proximal infrapopliteal arteries, you see some plaque, but in the distal arteries, many of these patients who come in with occluded 3 vessels below the knee, it's all chronic thrombus. And perhaps the combination of rivaroxaban with an antiplatelet agent can help prevent some of this. This is not the definite mechanism, but it's definitely an interesting hypothesis that needs to be confirmed. More arteries distal frequently exhibited thrombotic occlusion associated with insignificant atherosclerotic stenosis, suggesting the mechanism of arterial occlusion may involve thromboembolism rather than thrombosis at a site of plaque rupture, which is classic what you would get in the coronary circulation. Now, Mark Banaka led this study. This is the Voyager PAD trial. This was a great study. Patients were randomized to aspirin or aspirin and low-dose rivaroxaban. They were allowed to be on clopidogrel for up to 30 days, and about half of the people in the placebo group had placebo plus aspirin, and about half the people in the rivaroxaban group were on clopidogrel for a while. There was no difference in the outcome in patients who were on clopidogrel and those who were not on clopidogrel. And the primary efficacy endpoint was cardiovascular death, MI, ischemic stroke, acute limb ischemia, and amputation. And the safety endpoint was TIMI major bleeding. And what you see here is that 77% of all patients had intervention for claudication, and 23% had for critical limb ischemia. These were a very well-treated medical group. I mean, this was part of the design of the study, that they had to be on a statin, ACE inhibitor, aspirin, and it was up to the practitioner whether or not they were on clopidogrel for some period of time, but it was strongly encouraged that the clopidogrel be stopped after a month and definitely by 3 months. And here's the Kaplan-Meier survival curve. You can see the group with aspirin and rivaroxaban had a relative risk reduction of 15%. And this came with some increased bleeding, but there was no intracranial difference in intracranial hemorrhage, fatal bleeding, intracranial or fatal bleeding. So the conclusion of this study was that in patients with peripheral artery disease who have undergone lower extremity revascularization, rivaroxaban at a dose of 2.5 twice a day, plus aspirin, was associated with significantly lower incidence of composite acute limb ischemia, major amputation, myocardial infarction, stroke, or death from cardiovascular causes as compared to aspirin alone. Now, this was just published, and this helps us decide which patients should we put on this regimen, because if bleeding is increased, you don't want to put every patient on this regimen. But this allows you to put the highest risk patients on a program like this. So you already know what the COMPASS trial showed, and what this study, here's all-cause mortality, cardiovascular mortality. What this study showed is that of these 4 comorbidities, polyvascular disease, that means vascular disease in more than one location, renal dysfunction, heart failure, and diabetes. If you have none of these, then it's probably not beneficial to put patients on this combination. The number needed to treat is too high. And then if you have 1 out of 1 out of 4, 2 out of 4, and 3 out of 4, you can see that the risk becomes much more beneficial, the outcome more beneficial, the number needed to treat decreases considerably. So I would definitely put people who had 2 or 3 of these comorbid events on aspirin and aspirin and rivaroxaban compared to those who are less sick. Now, I just want to bring up one other point. There has never been a study demonstrating that aspirin and clopidogrel is helpful after endovascular therapy. It's never been done. There was a trial called the COMPASS trial, which I was involved in over a decade ago, which was going to test that hypothesis. But after about 8 months, the study was stopped because we could not recruit. The interventionalists felt so strongly that aspirin and clopidogrel is the way to go that they did not enter them into that particular trial. So we, John Halpern, I, and one of our fellows wrote an editorial associated with this and essentially said, considering incremental risk of bleeding that arises when aspirin is used concurrently with an anticoagulant, as well as the cost and complexity of multi-drug regimens, physicians should select patients thoughtfully for what's now called dual pathway inhibitor therapy. The data that was provided in the paper I just showed you provides important new information to identify patients most likely to benefit from dual pathway inhibitor therapy. The absolute reduction of mortality achieved was most pronounced in those at greatest atherothrombotic risk. And I already mentioned polyvascular disease, diabetes, chronic kidney disease, or heart failure. Now, I just want to finish with 2 or 3 more slides. Everybody knows that an exercise program is what you should recommend to people who have claudication. But an exercise program is not like, hey, you get discomfort in your calf when you walk, just go out and walk more. That's not an exercise program, and nobody will do it. If you instruct the patient carefully, and this is a program that I give to my patients, only 1 or 2 out of 10 will actually do it. But those who do it really get a beneficial response. So if you have iliac disease, no-brainer. I would go with endovascular therapy first. If you have SFA disease and you have claudication, I'd give an exercise program a chance, recognizing that it's not easy to go out and walk, and then when you get discomfort in your calf, stop and stand there for 2 minutes and then repeat that again for 45 minutes a day. But in the unusual patient that will do it, it is helpful. And then a structured exercise program, and we're actually trying to institute this at Sinai at multiple sites now. A structured exercise program actually is the most beneficial, similar to what you would get with cardiac rehab. What about the drug cilostazol, marketed years ago under the name of Plato? Let me tell you first that this should never be used to decrease MI, stroke, and death. It's got a number of mechanisms of action, but nobody knows how it increases walking. It should not be used as an antiplatelet agent, and there is no contradictions to its use with clopidogrel, aspirin, or rivaroxaban. So it works, but nobody knows how it works. Nobody knows the mechanism. This is one of 9 randomized prospective trials that have all shown the same thing, that at the dose you should use, 100 milligrams twice a day, patients get a significant increase in their ability to walk. But remember this, it takes time to get the maximum benefit, a minimum of 12 weeks. So if the patient stops it too early, they're not going to potentially derive a benefit from it. If you use this drug, remember these 6 things. It should not be used to treat the symptoms of claudication. It's not for it should be used for claudication. It's not used for cardiovascular risk reduction. Use the 100 milligram dose twice a day, unless they're on a drug like diltiazem, in which you have to reduce the dose. But otherwise, 50 doesn't really work quite well. Take it on an empty stomach, otherwise it won't be absorbed. Tell the patient it may take up to 4 months to get the full effect. If side effects develop, reduce the dose to 50, and if they're still there, stop it. Side effects: headaches, palpitations, and diarrhea. And there's a black box warning for this. It should not be used in people who have heart failure. It doesn't cause heart failure, but it's structurally similar to milrinone, which was associated with sudden death in people who had heart failure. So at 1 year, 60% of the people started on this drug are no longer taking it. And this is my last slide. Don't forget that many of these patients end up with amputations because of impaired sensation in their feet, from diabetes, et cetera. Make sure you inspect their feet, you get them fit into proper orthotics. And with that, I will stop and thank you for your attention.